Okay, our topic today is about managing a critically ill patient. As Dr. Ahmed mentioned, that when you have an ill patient, you need to manage that patient with the right decisions. So you are the decision maker. The difference between a doctor and other medical staff is that the doctor is the decision maker one. So when you have an ill patient, the pharmacists, the nurses, the laboratory technicians, and others is just following your decisions. They are just doing what they are told to do. They cannot take a decision. But you are, as a doctor, even a junior doctor, in some situation you need to decide and to behave. So when we have a cold case or a patient that's admitted to the ward, they don't have an urgent event. We can't simply call for someone and just ask them about what it should be done. On the other hand, in the critically ill patient, at some situations, you need to take the decision, you start your management until the help arrives. And this is the core of our lecture, how to build a submental thinking and decision making that will help us to deal with this situation without needing to go back to a more senior doctor or to our books. Okay. In British, they used the term of critically ill patient to describe these situations, like when they call you and telling you that some patient deteriorated suddenly and we need you to review this patient. You will go straight forward for that patient, you start your management, and then calling for a help until they arrive. So maybe you have 5 minutes, 10 minutes, or 15 minutes until a more senior doctor arrives, and this is enough to save his life or lose his life according to your behavior and decision. Okay. They have this ABCD approach, which is easily memorizable because it just reflects an alphabetic of English. Okay, I'll give you an introduction about what is the ABCDE, and then we have 6 cases we'll be discussing, and we just trying to build a submental state of taking the right decision. And by definition of the ABCD approach is a structured systematic method of assessment and management. So it's structured, so you know what to do first, and it's a systematic, so you are just jumping from side to side. You have something that you follow, that the nurse should know and follow, and the more senior doctor, when he arrives, he also follows the same protocol. So when someone interrupts you at some point, you just tell them, I just reached my C stage, and they might help you completing what you just started. And it's also an assessment and management. So you do assess and you do manage. Okay. So it's not just some theoretical thing. It's just a practical thing that you will be using in a situation that it will happen suddenly and you won't be prepared. So it should be like a driving. When you are driving a car, someone or something blocks the street, you don't need to think what to do. You just press the brake before even knowing. Okay. The behavior or the psychology behind the ABCD approach is that what kills first comes first is the most important thing. So what kills first means the thing that might cause a patient to die first, we should manage first. There's no benefit from dealing with other things, and there is an earlier thing that will cause death already. So if someone like having some problem in the disability, and we just ignored all of these and we jump to the disability, he will die because of one of the earlier things. So there's no benefit from managing B. So what kills first comes, you should manage first the A, then the B, then the C, then ongoing. First, the A is the airway. So the first thing when you are approaching a patient is to check for his airways. What means that the upper airways, if it's blocked and we just ignore that, we jump to trying to make him breathe. So for someone who is apneic and have a blocked airway, if he have a patent airway, you just proceed to giving him a support to the breathing, whatever the method. So you'll help him to breathe. If you jump to the B and he have already a blocked airways, he will not breathe. Whatever you do, whatever the method of assessing his breathing system. And also in the C, if someone is hypotensive and you just jump to manage his hypotension and ignore that he is apneic, so whatever fluids you give, whatever blood pressure he reached, there is no oxygen in the lungs deliver to the other parts of the body. So he will not get benefit from managing C before first assessing the A and B. Is that clear until this point? Well, this is the objectives of our lecture. What we need to know first, the definition, identification of life-threatening conditions. So when you are managing through the ABCDE, you'll just know what's the difficulty or what's the emergency of this case. Is it a life-threatening or is it just a simple thing? We'll know that by assessing the patient. The second thing is the prioritize the management. What should I do first? I can go from this room to other room, bring one thing and come back here. What is the thing I bring? I have ambo bags, I have a mouthpiece, I have a DC shock. So what's the thing, the first thing I will bring with me, or I'll send a nurse to bring, okay? The continuous reassessment, which means when you manage A and you go to the B, after B you won't go to the C. You go to the A again and B again and then to the C. And that's the meaning of reassessment. And the standardization, which means to decrease the conflict. When you have a patient, an ill patient, and you and your colleague is standing beside this patient. So someone says we need to do that and other says we need to do another thing. That will be a conflict or between you and the nurses. So this is the standardization. All of you will accept to follow one protocol that is you are following, so you will be helping each other. The most valuable thing in the most valuable thing in the ward, in the emergency department is you. It's not the patient. We don't need to lose a doctor in order to save one patient. You are the one who is saving hundreds of patients. You are practicing medicine. You and the medical staff is the most precious thing in all the situation. Whenever you need to protect someone, you should think to protect yourself first. So there is something which is called the personal protective equipments. And these are the equipments you'll use to protect you from the danger. If the patient is dangerous, you protect yourself from the patient. If the environment around the patient is dangerous, you need to protect yourself first. So when you call you for some critically ill patient, the first thing you need to think is to protect yourself, okay? We need to keep that in mind. So the first thing, I protect myself, then I'll go to do my job. The second thing is that when I'm approaching a patient, I just stand at the door of the room. I'm just going to enter to the patient. So before entering, I protected myself. I wear the suitable equipment that protect me. It could be just like gloves. It could also involve a face mask, a gown, whatever, head cap, slippers or shoes cover, okay? Then I'll be going to the patient. The distance from going to standing from the door until reaching the patient is called the doorway, which means the few steps you will take until you reach the patient. Or at some points at the ER, you might be sitting and the patient is approaching you. You are just waiting him to arrive. These few seconds from the door of the emergency department until he arrived to you is enough time to do this doorway assessment. So the first look, you look at the patient, you need to look for specific things. It's not just, we didn't start the ABCDE yet, but we started our assessment from the first early moment the patient arrived and we saw him. The first thing, we need to look at the patient. Is he looks critically ill? Is there any signs looks at him that make you suspicious that he's critically ill? Like, do he have a cyanosis? Is he comatose and looks completely unconscious? Is he having maybe facial trauma, some body trauma, amputated limb, or anything else? So the first look, you look at the patient. The second thing, the consciousness. When he arrives, if the patient arrives on bed, it's just some blind thing. You don't know what to do. You don't know what he might have. But if he comes to you walking, that is very reassuring for us, okay? So the conscious level is important. So when you see a patient is opening their eyes, is looking to you, is sitting on the chair, or is walking, it's very reassuring for you that his condition might not be that dangerous. But on the other hand, if he is unresponsive or unconscious or agitated, that reflects something more serious. The third thing is that the respiratory distress. When patient comes to you with some bleeding everywhere and he is unconscious, the other thing you need to see is that his pattern of breathing is apneic or he's breathing. Does he have shallow breathing? Does he have an active bleeding? Any sounds of stridor? So the breathing pattern of the patient. Is that clear until this point? Okay, I'm sorry that we take too long, but this is an image and we do our walk doorway assessment. First thing, we wear our equipment and we are just approaching this patient. Can anyone share with me what is he seeing? You are just standing at the door and looking at him. Anyone want to share his opinion about this image? Yes, doctor. Obviously, unconscious patient. Yes. Accessories of good. Patient is critically ill. Maybe this is intensive care unit. Yes. And there is, I guess, nursing. Yes. Yeah, my baby anesthetic assistant. They are just working with these devices of anesthesia. Yes. So I would describe him as a critical ill patient. Perfect, good. Such a patient with, as the doctor said, something comes out of his mouth, maybe an endotracheal tube mostly, and he have a cough, non-invasive blood pressure monitor, and some IV lines running from that side to him, and all these equipment behind him. So we don't suspect that they call us for this patient for something silly. So we just take it seriously, and we just should react in a proper way with such a patient. And that's all that assessment is just before reaching the patient. We are just standing at the door looking at him. Is that clear until this point? Perfect. Well, we just arrived to the patient. Before starting our assessment, we need to look for something. The first thing we need to do is to confirm his identity, which is a very critical thing, and that happened to me personally and to many of the doctors in the daily practice. You just assess the wrong patient. You just arrived, see someone in front of you, and you just assume that this is the patient, and you started your management, and then it turns that he's completely not the same patient. So the first thing you need to check the identity, then we need to ask some basic questions. It's called a brief history. So before starting your assessment, you need to take a history if the patient is conscious. So the identity, you just ask the patient, can you confirm your name and age please with me? Okay, for me, sorry. Then he will say or not. If he is unconscious, he will not respond. If he responded and he said, that is very relieving, because that means he is conscious and he is responsive for you and he is aware. Okay. Then you can ask him about these questions like allergies, so you avoid some medications or things that cause allergy, like latex from your gloves, medications he's taking, previous medical history that might reflect some disease that causes this illness, last meal, because you might take him to the theater, so you need to know when the last meal, and events leading to this presentation. You just tell him what happened and he will answer with a few words. If the patient is unconscious, it's more tricky. In other countries, like in UK, and when we trained on assessing critically ill patient, when an unconscious patient comes, they should put a label, the bracelet on his arm, which contain his name, age, and patient's number, and things like this, which is which give us the identity of the patient. So you never starting managing a patient, even in Iraq, in our locality, you can ask his relatives, who is this patient, what is his name, what happened, and you take a brief history from these and checking at it before starting any assessment. These are an image of some bracelet you might see. It's not common in Iraq, but some patients have a cards in their wallets tell you about their allergies. So many patients carries some cards which contain information about his previous medical history, like he's on a steroid. So some patient on a steroid, they should put a card in their wallet, and some types of allergies, they put these cards. So are we clear until this point? We should protect ourselves. We look at the patient, do a brief assessment in the doorway assessment, and then we just checking his identity. Until this point, we can now start our ABCDE. Okay? First, the A. A means airway and protection of the spinal cord. You know why we put the cervical spine protection with the airways? Anyone have an idea about this? Yes. Like, sorry, like what? Yes, exactly. Yes. Well, maybe, but what the doctor said is more clear, because in the airway management, one of the part is head lift. So if someone have a fractured vertebra and you just lifted his chin, they will cause a complete spinal cord cut. And as a part of the management of the airway is injuring the spine. So we need to check for the spinal vertebra before tilting the head of the patient. So in the airways, we come to the patient checking for the airways. We can do simply three things. First, we ask the patient, may I confirm your name and age? If he answered, this means a patent airway. Patient with a blocked airway will not produce sound. Okay. Then, if he did not respond, not because of a blocked airway, but he might be unconscious, we go to the second one. We listen. Is there any breathing sound? Is there any stridor? Is there any wheezing sound, which reflects a partially obstructed airways? Then, if nothing is shown, we go to the look. We open the mouth of the patient and we just look inside for any blocking cause, even his tongue. Many of the patients swallows their tongue with a sudden losing of consciousness, and that will block the airways. Is that clear until this point? In the airways, if we have any blocked airways, you need an urgent assistance as soon as possible. You cannot do anything until the airway is open. So if you have a blocked airway, you just go to elevate the chin and jaw thrust, or maybe intubating the patient in order to bypass this obstruction. Also, you can sucker, because some patients have a bleeding in the mouth with the clothes that block the airway. So suction is one of the choices. And the first one to do is to call for someone specifically for the anesthesia, and maybe the ENT team, which might create an tracheostomy and bypass the upper airway in order to make the air reaching the lungs. Okay. So this is all about the A, which is simple. Think, if the airway is blocked, it's beyond your abilities. If it's patent, you go to the next one. The B. In the assessment of the B, I just create something to memorize that. I start from the end of the bed, going to the side of the patient, doing a chest examination or respiratory examination. Starting from the end of the bed, even in what we studied in the normal examination, we look at the symmetry of the chest expansion and yes, exactly. Maybe abdominal or chest movement with the symmetry of the chest expansion bilaterally, and counting the respiratory rate maybe at this point, just to memorize that. Then we go to the patient, we just examine the chest. We look for tracheal deviation, might be tracheal deviated to one side, with a palpation, with a percussion. We percuss, searching for any dullness, hyperresonance, or normal resonant chest. And then with auscultation, we search for breathing sound. Is it a good harsh vesicular breathing or a diminished or muffled breathing sound? And then we check for the oxygen saturation with the oximeter at this stage. So you need to assess the oxygen at this stage. If there's any diminished oxygen supply or decreased SpO2, we can manage that. Something you can add here just to memorize that, we need a chest x-ray. In most of these cases, we just keep in mind that we need an x-ray according to our assessment. Then we move on to the action. We assist. We find that the saturation is low, whatever the cause. What we should do, we should administer high flow oxygen. And ideally, according to the General Medical Council, the oxygen supply is 15 liter per minute via non-breathable mask. Okay, 15 liter of oxygen, which means a fully opened oxygen via a non-breathable mask. The non-breathable mask, which have a bag. I believe that they brought one today. We'll be seeing that tomorrow. So, okay, we need to supply oxygen. Whatever the method available to us, we need to supply oxygen at this stage. We do not delay that more. And then we might have an assisted ventilation via ambu bag mask if the patient is apneic and there is no breathing effort. So after checking that the airway is patent, we need a breathing at this point. There is no excuse to delay that until a later point. And I put the chest x-ray here within the assessment and management. Yes. Yes. Well, this is there's a very good point. If you talk history and you know the patient is adapted to a low saturation, whatever the cause, whether a COPD, any lung disease, or even yes, exactly. We don't know, but if you know that the patient, you keep him on a 5 liters per minute of oxygen. But this is should be after assessing. You don't need to keep a patient hypoxic while you are not sure that he's adapted to a low saturation. Is that clear? So it's the normal thing, the default thing is that we put him on a high saturation until
high flow oxygen, right?
Sorry?
It's like a standard thing to do.
Yes, exactly. The standard thing is to give the highest flow of oxygen. But if we know and we are sure that this high flow oxygen will harm the patient, we might decrease that. We will not decrease that from the beginning, fearing of having some. Even if he developed a respiratory depression after increasing the saturation, we can manage that later on. But if he have a hypoxic brain and a permanent brain damage, we cannot fix that later on, right? Within the C, we have a circulation. I just assist that, it's my own way to remember that. I just assist the hand of the patient. I start with the tips of the fingers. I check for the cyanosis, okay, which is the peripheral cyanosis. I just go a little bit to check for the capillary refill. Normal is within 3 seconds, the refill happens. So the tips for the cyanosis, for the nails for capillary refill, and then the radial pulse and the ulnar pulse. The radial pulse for the volume of the pulse, for the rate and the rhythm. All right. Then I go just in the forearm. I remember to put an IV line, which is an important thing at this stage. And then I go a bit more to put blood pressure and invasive blood pressure monitoring cuff, so I can assess his blood pressure. And I go a bit more to reach the chest to do an ECG. I just memorize that in this way. So at this point, we need to check for these things that we just mentioned. We then, at this stage in the C, we should secure an IV access, which is 1 line, 2 line. We might give a central line. We might use an intraosseous line. Okay, so we need to secure an IV line to this patient at this point. And then in the sepsis, they just say take 3 and give it 3. You might remember that from the college. So we need to take a blood sample before giving anything. After giving medication, many of the tests will not be correct enough. So I just want you to remember that we secure an IV line, then we take something like the complete blood count, urea and electrolyte, ABG for blood gases, and blood group to prepare blood, and then give Hartmann solutions, blood products, some medication, suitable medication like antibiotic, adrenaline, and something else. Okay, that will be in depth more dependent on what we suspect until this point. Yes. Well, we are checking for whatever pulse we can detect. So checking for the radial pulse is the most common thing, or the well-known thing. We can check for the brachial pulse, ulnar pulse if it's detectable. But if the radial pulse is weak, we can move more proximal. Moving more distal is not with no benefit. So the carotid pulse will be detected in a much lower pressure than the radial pulse. Okay, but you can check whatever superficial pulse that is possible for you. The femoral pulse might be popliteal or dorsalis pedis or posterior tibial. Then the D. The D, where we're moving through the ABCDE, you see that the critical and the urgency of the case is diminishing. So these things will not kill the patient at few minutes, like what airways do. So at this point, if the patient is unconscious, we are just assessing at the D. In the D, we check for the disability and the neurological state. We calculate the Glasgow Coma scale for the patient at this point. We see if have a Glasgow Coma scale below 8, that means he's in a deep coma, and we might need an assisted ventilation. And also, at this point, we need to check for blood glucose and temperature. It is within the D, despite it's not a neurological, but one of the causes of losing consciousness is hypoglycemia and hypothermia or hyperthermia. Okay, so at this point in the D, the patient is unconscious. We need to know what is the cause of unconsciousness. We check for Glasgow Coma scale, we do a glucose, and we check the temperature. Is that clear until this point? And accordingly, whatever we find, we can manage, but it's not that urgent as we started. In the A, if there is any problem, you call for someone. In the B, you start your management immediately. In the C, it's much more time giving, or it's not forgiving. And in the D, you can manage it slowly. Like if you suspect he have an opioid overdose, you might give an oxazolone, which is not common in Iraq. Then in the E, it's looking for anything else. We start exposing the patient from head to toe, looking for anything else that have not been assisted during the previous assessment steps. So in this step, we just looking the face, we might assist that in the A or in the B, the chest also. Then we are looking for the abdomen. We are looking for the groin area. He might have some bleeding, some distended abdomen. He might have a Foley's cath, which is filled with blood, or he have a bleeding per any of the orifice. He might have in the limbs. Lastly, in the limbs, he might have a fracture, which is not an important thing, despite I'm an orthopedic, so I should be starting with these. But this is the right thing. The fracture is much slow or much less urgent than what we just mentioned previously. So if you find someone with an obvious deformity in his arm or an obvious deformity in his leg, this is not important. You just go through the ABCDE, and when you reach the E and you look at his limb, you can just manipulate it, sublint it with whatever. And these temporary sublinting we are doing, the back slab or a sublint, we are applying in the secondary survey. It's not even in this state. So we just keep alignment of the limb to protect further damage from further damage and avoid further blood loss, and that's all. We don't need to do anything with the fracture at this point. And it's simply a simple thing that we need to cover the patient at this point, despite we say the hypothermia in the previous in the D, but and we will expose the patient, so we will not keep him exposed in a cold weather. So we need to cover him after finishing our assessment. Sorry for this long lecture. I wish you didn't get bored so fast. So we'll move on to a more interactive. We'll have 6 cases. You will be managing them. Okay. What you see here is that this is called, it's a mannequin in UK. They call it a Simman. It is a large mannequin, a full body. He can blink. He can talk. He have a breathing sound. He have a radial pulse. They are just attaching a fake or a simulating monitor to him to show the vitals, and you just go in this station in one of the blab exam. You might hear about it in the OSCE exam of the blab. You just approaching a critically ill patient and starting management. Mine was having an allergy from a blood transfusion, and they just put a paper, a skin rash printed on a paper here, and they were covering the patient. And I didn't see that until I reached E and exposed the patient, and it's shown. And I understand that this case is allergy from my blood products, and I managed accordingly. So what to do next? You finished your ABCDE, and the patient now is better. And even if he didn't improve, what to do next? Should I just keep in ABC? You need to move to the next thing, is that reassessment is the most important thing in the ABCD. If you manage the airway and you move on, you reassess the airway, it might be blocked again. So there is no benefit from whatever you do later on if the airway is already blocked from the early beginning. Monitor to the response. So when you are doing something, you give a fluid, you suspect that, or you are predicting that the patient blood pressure will increase. If it didn't increase, that's an important sign. You are dealing with the non-right, you are not doing the right thing. You are going in a wrong direction. So monitoring the response is a more important thing. The definitive management, which is not your job, so you need just to order some investigation and x-rays and escalate that to the specialist or a more senior doctor. Documentation, which is the most important thing. Dr. Ahmed just talk a lot about protecting yourself, and he have a lecture today about the medical legal issues. And recording the finding, it's a part of the documentation. And then later, hand over, when you are just giving the patient to the other hands. So you are you finish with the patient, they are taking the patient, or you talk the patient into other place like the ICU. You just give them the background, what you know, your assessment, and your recommendation. You say that I recommend that you want to stop this fluid because I suspect the patient have an internal abdominal bleeding. So I am advising you or recommending for you that the fluids should continue, and he receive a blood product as soon as possible. You just deliver them what you know earlier. Okay. So just a recap: you protect yourself, then you approach the patient having a look, Then you start by checking identity and you go through the ABCD. Now I'll give you a scenarios that is, I believe that you'll face in your practice in the future, and it's just a training to your mind to use that submentally. So you are just adapted to do that. There is no need to think about it. It will come from its own. Are you ready to start? Okay. So the first case, some patient come to you. He is an 28-year-old male involved in a road traffic accident, which is a high-speed collision. The person who bring him, like the ambulance or the paramedics, told you that it's high-speed collision. They found him unconscious and brought him to the emergency department, and there is no known history. They don't know anything about this patient. What to do? Yes, perfect. Well, what to do? We are doing ABCD approach. Okay. Yes, simply. No, you don't need to call for help from this point. No, you just assist the patient. You take a decision of getting help. So you are one. You are the one who is, they are calling. They are calling for the help. They call for you. If you call for someone, who you are? So what's your job from in this situation? Okay. So you are the only doctor present at this area, and the help will need a few minutes to arrive. So you are the one who is assisting the patient. So yes, so it's the ABCD approach. So first, the airways. By checking the airways, he have an incomprehensive sounds. What do you think? What we should do at this point? Airway patent. Yes, it's patent. It's the only thing is that it's a patent airway, and the patient is producing an incomprehensive sound. The patient do not need to talk to know that his airways is patent. Any sound he's producing, even a blah blah, it's a sound. So his airway is patent. So this gives you a clue that his airway is patent. Sorry, yes. Sorry? Good, perfect. Since it's a high collision, and he has an incomprehensive sound which reflects maybe a head trauma, so we need to protect the spine from the early beginning, which is a perfect point. What else we should do? Yes. Sorry. Yes, good. But is this in the A? That's what we are just learning today. Yes, exactly. That's what we are learning today. We don't need to jump. We don't need to secure IV lines at this point. Clear? Because it's in the C, so I don't know to do something coming from the future. If there is if there's 5 people around the patient, you can order someone to secure an IV line while you are doing your job. You are just giving that duty to someone else. You don't need to think about it. Okay? So yes. Maybe suction. There's any like fluid. Yes, maybe. Yes, maybe. So according to the fine, yes. Consultation to the maxillofacial. Yes. Well, since it's a comprehensive sound, is that reminds you of Glasgow Coma scale? Yes, it's something in the low in the Glasgow Coma scale. In the yes, 3. Yes. B2. 2. Yes. Yes, 2. Okay, because it sounds not in a proper word. Yes, so it's sounds, just a sound, not a words. So it's 2. So that reflects a Glasgow Coma scale. So we are just doing a jaw thrust to protect him from swallowing his tongue. Okay, and then we apply a C protection like what your colleague said. In the B, we just check that his breathing sound is diminished on the right side, and he have a hyperresident right side, yes, with a tracheal deviated to the left side. What that comes to your mind? Is it? Yes, perfect. It's an pneumothorax, then we can say it attention later on, according to other findings. Okay. Yeah, yes, exactly. I mean, in the B, we don't know it's an attention, but it's a pneumothorax, obviously from a hyperresonant test and maybe asymmetrical breathing. All right. What we should do at this point? Yeah. No. Yes. Okay. Well, yes, doctor. Emergency needle decompression. Yes. Well, do you believe that if it was shown later on to be just a pneumothorax, we need to do a decompression? Yeah. So do you know that it's tension from this until this assessment?
Most likely.
How did you? What's the clue about attention? Yes. Well, the tracheal deviation is one of the signs of the tension pneumothorax, but hyperresonance and diminished airentry is not a sign of tension. It's a sign of a pneumothorax. Yes, perfect. We might inspect the chest to look for any open pneumothorax. Okay. Maybe. Well, we don't check for other thing than the B. We are just looking for the B. Okay. Yes. Perfect. This is the most important thing you should do. It's the most important thing you should do is deliver oxygen. Whatever the thing you will do, the most important thing is to give him an oxygen. You help the functioning lung to do its job. So yes. Why? Delivering oxygen is not under pressure. What might cause a tension pneumothorax to be converted to a tension is that we just compress the air into the lungs, like a mechanical ventilation. But when you are just putting a mask and delivering an oxygen, an air that is not rich with nitrogen, like what's our normal air is about 70% of life. We just give about maybe 50% of oxygen. So the few amount of air that will enter is rich with oxygen that will help the functioning lung doing its job. Okay. So I'm not with this thing because it was just here, but giving an oxygen is the right choice. Giving oxygen is the right choice. But we might do decompress the chest and putting a chest tube rather than, it's not your job, it's more senior doctor job. But your job at this point is delivering oxygen. And you can just consult someone to help you with taking decision regarding decompress the chest. In our practice, you will never decompress a chest. You will never secure a chest tube. You'll never. Okay, whatever the situation, because legally you are not allowed to do so. Then the circulation, we found that he is a hypotensive, tachypneic and cold extremities. Is that gives a clue about shock, which is might be caused the type of shock? Hypovolemic. Do you think that this is a hypovolemic neurogenic? Do you think that this might be a neurogenic? Some more obvious shock, cardiogenic shock, like the heart cannot, obstructive shock. It's called an obstructive shock. The heart cannot pump blood because it's compressed by the lung. This is the thing, the obvious thing. Like in tension pneumothorax, we have an obstructive shock. Okay, it's not a wrong thing. I cannot judge that this is a hypovolemic, but why I'm suspecting generally, whatever the diagnosis, he has a hypovolemic, tachypneic, and tachycardia, and cold extremity. What we should do at C? We come back to the point of the doctor. We should secure 12 blood, yes, lines. Then we take something and then we give something. What we should take? Yes, blood sample to prepare for blood, maybe a hypovolemic shock, and maybe taking for some investigation, checking for other. Yes. Yes, exactly. But what is obviously shown, it might be obstructive. But yes, we manage as a shock, and the type of the shock is not within the ABCD approach. You don't need to know the type of the shock. You don't need to know. You just follow what you have, and you manage that accordingly. Okay. Is there any medication we might give in this situation? Yes, I want to want you to fall in this trap. So why do you give a vasopressor? What do you think? Sorry. Yes. Painkillers. Well, it's a good point, but the patient is unconscious, so he might not be feeling pain at all. So, what type of painkiller? If you give opioids, which is a respiratory suppressor, so you might do more harm than good. So, okay. You secure a large poor IV access and you give fluids and prepare for a blood products. Okay, you prepare for a blood products. You do not just start giving it. Then the D, his Glasgow Coma scale is 9 and the pupils is equal reacting to the light. What we should do at this point? Well, it's much easier because there is no critical thing. All the critical things we managed earlier. The wrong decision, if you take the wrong decision in the A, you might kill the patient. In the B, you might kill the patient. In the C, maybe. In the D, it's more forgiving. So it's you have a more large area to deal with. So what do you think? Yes, it's a Glasgow Coma scale is a 9. So we just examined. Sorry. Yeah, I know. We have a Glasgow Coma scale. So we jump to the management. I finished the assessment for you. You just give me a manage. What do you do in this situation? Yes, well, you call for some help for anesthesia to maybe intubate. They take the decision, but we just calling for them. They might come and help us with that. Okay. At this point, your action is monitor for the Glasgow Coma scale. After doing the previous management, he might be hypotensive, decrease the perfusion to the brain, causing a decrease in the consciousness. After giving an IV fluid, his Glasgow Coma scale might improve. But you don't know if it's improved if you didn't check that frequently. So you need to give a baseline. You check it now and check it later on to see if he is improving on your management or worsening even. If there is some intracranial insult, it might be worsening over time. Well, intubation and an ICU admission is indicated, or assisted ventilation, sorry, is indicated when he is 8 or below. But 9 is not a good thing. It's a really critically ill patient. Yes. Yes, exactly. But even the moderate is something serious. Even the moderate is something serious. Then the E, he have a multiple abrasions and possible bleeding site. What would you do? Yes, perfect. Yes. Yeah, we cannot stop, but we control as much as possible. We might train you tomorrow about how to control some bleeding, especially if the visceral bleeding. I mean, in the extremities, we don't afraid. We are just dealing with that in a good way. But when something internal, we cannot reach it directly. It might be surgical intervention. So yes. Why? Yes. So yes, it's not within the protocols to give an tranexamic acid for an or some suspected bleeding. Okay, it's uh, it should be following the guidelines. We should not suspect things. So you might give anything that you suspect that it might improve the patient, but it's not well known to give antranexamic as a primary control for bleeding, except for some situation like peptic ulcer and things like that. We might use that in a specific situation according to the diagnosis. But in general, when we see a patient with a multiple trauma, we just not jump to the tranexamic acid. We might use that if our assessment showed that it would be beneficial in this condition. Okay. Yes, exactly. We might give we might give an tranexamic acid in some situation, but we need to assess if someone has a bleeding or a deep wound in his arm, and we just control that bleeding. Tranexamic acid will add nothing. We just apply the tourniquet proximal to the bleeding site, and everything is solved. You don't need to. So accordingly, you should manage the bleeding at this point. Before that, if there's a massive bleeding, we might modify the protocol, like what American Heart Association says. ABC, the ABC, it's a part of the ABCDE protocol. We might have a CABC, which is controlling the major bleeding, then we go to the ABC, which is a rare situation. We didn't deal in these cases because that is a mainly different thing, okay? Someone with obvious bleeding, we need to control bleeding, then move on to our examination. Yes. Yes, unresponsive. Unresponsive what? Well, if there is some bleeding, we need to control that. If there is no bleeding, I don't know what we should do. Okay, I don't know how would we manage a bleeding that we are not sure about its presence. So I won't delay the A until I reach the diagnosis of the source of bleeding. Is that clear? If we have an obvious bleeding that we can control, you just prioritize that before anything, because everything you do, you are losing blood. If there's a multiple people with the team, you can give someone the duty of controlling the bleeding while you are going back to ABCDE. Right? Yes. It's advanced life support. Yes, you start with giving him breathing as soon as possible by ABC. But if there is a cause of that, there's an obvious circulation cause of that, you might go to the circulation first. Okay. In the emergency department, I promise you, I have multiple years practicing medicine. You won't face this CABC. You won't face that because the massive bleeding will not arrive to the ER alive, because we have about 15, maybe 30 minutes from the incidence until the patient reach you. So with the massive bleeding, they almost always arrive dead. Okay, and even there will be no bleeding, they have no blood left. All right. So during my practice, I never faced any case I need to control that massive bleeding, except from one case. Maybe I remember he had a femoral artery injury, and we just pressed on that and we continue our job. We didn't do much. We just press on it and continue our job. Okay. And this is, we deal with large wounds and stabilize the fracture. This is simply the thing. There's operations, we just need to cover that, control whatever it can be controlled. So what to do next? We just finish our job. What to do next? Yeah, good. Maybe an investigation like CT scan. And sorry? Yes, whatever, if he improved or not, and we finished our job. If he didn't improve, we didn't finish, so he should be improved. Good. Further investigation, like a CT fast, X-rays, things. Yes. Perfect. It's within the E, so we already examined him from head to toe, and we checked for any possible other injuries. Then we should examine the blood sugar in the examined, not tested, because it's a bedside test. So we should examine the blood sugar in the E, in the D. Perfect. We just hand over him to another one. I just finished my job, so I need to do things like monitor the response, like what you mentioned. We just see if he improved, and then call for the specialist. It's not my job to just monitor the patient for a few days and discharge him home. I converted him from a critically ill to non-critically ill, and that's all. It's my job is finished here. Then we might order for some imaging, like what you said, and documentation, which is the most important thing. You document, and he might be admitted to the ICU. So a multidisciplinary team is managing him, since he might have a cranial insult, spinal, a chest, and multiple fractures. So multidisciplinary team is managing this case. Yes. Sorry. Yes. Yes. Well, if you causes unintentionally an injury to the lung, to the heart, to the esophagus, or the mediastinal structures, what would you do? Who will protect you? So in Iraq, I promise you that you will never do an immediate compression unless you are under supervision. Yes. Yes. But if you call me, if I was an orthopedic, which is not a part of my job, and you call me and tell me that this patient might have a tension pneumothorax, which I diagnosed via my assessment, which is a hyperresonant, and that everything else, and I gave him an oxygen and IV fluid, that is a perfect job. I'll be climbing to you on the phone even before coming to the AR. What other colleagues do is just calling you and telling you that this patient is unwell. I don't know what. So these are all the information some doctors provide to us as a more senior doctors about these patients. So just calling me, telling me that this patient is unwell and I don't know what happened. So if you do this assessment, you don't need to go advanced and intubate the patient or decompress the chest. No, you just go through these and do the proper management according to these basics, and that will be more than enough to keep him alive until more help arrives. This is the second case. We need to calm down and we'll go slowly to the next one. This is a 40-year-old male. he presented with a sudden severe epigastric pain and then turned to be a generalized abdominal pain, and he had a long history of non-steroids. You have some suspicions now, and what we should do? ABCD. First, the airways, he have a patent and he's speaking to you. What we should do? Maybe. Sorry? Perfect. We don't have much to do in the A because everything is fine.
He's speaking already.
Can we? Should we protect the spine? Yes. We don't need, because the patient is conscious. We can simply ask him, "Do you have any problem in your neck? Can you move your neck?" Yes. It's in.
Everything's fine.
Yes. Then in the B, no intervention needed. Just monitor for the airways. It might be need a reassessment later on. He might develop to be unconscious and things will change. In the B, he is a tachypnic. What we should do? Okay, which is a 15 liters per minute via non-rebreathable mask. This is a standard British procedure. Then the C, he have a tachycardia and borderline blood pressure. So he is not just hypotensive, but he have a borderline blood pressure. What comes into your mind? Yes, which is a hypovolemic shock. Which state in the hypovolemic shock present with a borderline blood pressure and tachycardia? You remember? One or two? In the one we have a normal blood pressure with increased blood pressure with decreased pulse rate. We have a tachycardia already, but in the borderline blood pressure it's more towards B because the blood pressure is not normal. What we should do? Perfect. Yes. We secure an IV lines, then we take, then we give. What should we take? Yes, for a complete blood picture, electrolyte and urea and electrolyte and blood group. This is the most important thing. In UK, the standard thing is to give O negative blood until the compatible blood group is prepared. But in our practice, we don't give an O2 negative for any patient unless he's an O negative patient. So just remember that we need to give a blood. We prepare for blood. We have this rapid method of preparation which takes a few minutes. So you can give an IV fluid until it's prepared. So we put an IV lines, fluids, then a blood test, and prepare for a blood transfusion. In the D, he is alert but distressed. What we should do? Maybe if he have a pain, we should know if he have a pain. But he is distressed, he is not comfortable. So if we give a further non-steroids, then okay. So we might give him an opioid. It's okay because he's conscious. Okay, we might check for hypothermia and things. Analgesia. Yes. We opioids always in the ER prefer to give an opioids. Multiple cases which comes to me and to other colleagues. We give like non-steroids. They develop some complication like sudden abdominal pain. Even some patient, he was a young man. I give him diclofenac, which is a Voltaren ampoule, and he just developed a very, very massive allergy with angioedema, so it was risky. Yes, well, if he is intubated, then give opioid also. There is no need to afraid of respiratory depression. Okay. He have a rigid abdomen because we expose him in the E and we examined him from head to toe. The abdomen is not a part of any one of the previous examination. So now we have this rigid abdomen. What we should do? Yes. Management, yes. Perfect. Perfect, good, which is a good thing. Well, yes, it's not a part of the ABCDE to put a nasogastric tube, but you just having this recommendation is a perfect thing. You just call for someone and telling them, I recommend that this patient might need something. Like if you call the resident, the general surgery resident, and telling him, I'm suspecting this patient have a bleeding peptic ulcer, and I recommend that we decompress his stomach urgently, he might come to the ER bringing his equipment with him, or even preparing the theater, preparing for his urgent surgery. Is that good? What, I don't know what's written, but urgent surgery consultation, antibiotic maybe because it's peritonitis. So starting antibiotics in these severe infections is very protective for the patient. What will you do next? Yes. So yes, more further tests. Okay, perfect. Then yes, further tests. Erect abdomen. It's yes, it's a primary. We don't go to the secondary survey in the ABCD approach. Perfect. Perfect. Perfect, perfect. Consultation and documentation. They always remember to document, because in the critical situation, you will just do whatever you can do. And once in my practice, I just manage a patient from, I believe, from 12 a.m. to the morning, about 8 hours of patient who is arrested with a VF multiple times, maybe 2 to 3 times. And at the end of the day, I find that there's someone calling me, telling me that this patient died, and you never saw this patient all the night, because the patient was admitted on my call, and I was just managing her without writing anything in her documents. So they came in the next morning, find that I didn't write anything, and the patient just died. And they told me that you didn't do anything for her, but fortunately her family is there, and I just explained to them. So documentation is a protection for you and for your effort. Whatever you do, write it. It's only a protection for you. No one will blame you because you write something. You just write what you do. So monitoring the response according to our management, which will give us an idea about the diagnosis. It might be not the right direction. Consultation, documentation, and admission to the surgical ward for urgent surgical exploration. Are you ready for the next one? Well, you are getting improving. You are with 2 cases. Your just mentality is just improving with taking the right decision. You are not jumping to the circulation, leaving out what is most important. So we are just improving with practicing these simple things. A 60-year-old female. She is a 6-hour post-abdominal surgery. She is in the surgical ward. She did an abdominal surgery. It was a long surgery, and then she developed a dizziness, a collapse, and the drain is an increased amount of bloody discharge. Okay. What do you suspect? Good. Perfect. Post-operative bleeding. What we should do? Okay, with the A, the patient is the airway is patent but weak voice, so she can talk with a weak voice. That is relieving because the airway is patent, but she have a weak voice, which might be related to the neurological state rather than the airways. Prepare for the airway support, which means that we don't need to do anything, but we suspect. Yes, what I mean that we might need a help, so we just keep that in mind. But at this point, nothing to do. Then the breathing, she's tachypnic. What to do? Sorry. Yes, oxygen. So we need to give a high flow oxygen. In the C, she is shock. It's hypovolemic. Like she. Yes. I say the hypovolemic because she's tachycardia. She's have a hypotension, and she's pale, and that's all referring toward. So we put an IV lines. Then perfect. We take, then we give. We take a blood investigation. Perfect. That's all. Yes.
She's already bust up, so I think we already done our investigation, right?
Well, if she is doing a surgery, so she might prepare the blood, but she might not. So you are just not assuming things. You do what you do. You just take a sample and ask for a blood. If there's a blood, they will bring it to you. If there is not, they will prepare one. Okay. For the IV lines, she should have an IV line. She is a post-operative patient, but we don't assume things. You go and check for the IV lines. If it's not working, you secure a new one. Okay, so it's the same steps. Even if it's there, we just need to recheck that, not to forget the things. D, she is confused. The low perfusion, I mean, there is no some neurological event, but she is hypotensive, so she might be confused. What should we do for a confused patient due to hypoperfusion? Yes, exactly. There's nothing to do for this patient specifically in the D because it's in the C. It's always already managed. So we just monitor for the Glasgow Coma scale. If it's improved, that means our patient is improving. It's worsening. That means our patient is worsening. In the E, the bleeding from a surgical site. So you just expose the patient. You look at the abdomen finally in the E, sorry, and you find that there is a bleeding, a bloody dressing. That's what they call it. So what we should do? You might do like what the doctor says. Yes, we try to control bleeding, like giving tranexamic acid or doing anything else like packing. But uh, we, after doing a direct pressure, it should be turned urgently to the operative theater. So what I mean is that there is no benefit of whatever you do for such a patient trying to control the bleeding. It's a surgical case. You don't need to delay him for maybe 30 minutes trying to manage him in the ward without urgently referring him to the surgery. As soon as possible. Once you see there is a bleeding from his surgery site, in orthopedic, it's more forgiving because you might apply pressure which cause a tamponade and stop bleeding in the extremities. But in an open cavities like in the pelvis, abdomen, and chest, there is no benefit of these. So you need to call the surgeon even before applying pressure. Your pressure won't add that much, but calling a surgeon and referring him back to the surgery will do a lot of benefits. What to do next? Yes, further investigation. You order, or you might recommend. Just recommend. I recommend that he do that, and the surgeon, when he arrives, he saw your recommendation, and then he decides. And then you go for a special consultation, urgent surgical intervention, possibly, and documentation. Okay. Okay. He's a Chinese man, but it's okay. He's a 22-year-old who is asthmatic, and he has presented with a progressive shortness of breath with no response to his own inhaler. What do you think? Yes. Status asthmaticus, maybe. Yeah, I mean it's the asthma which is not responsive to the medication.
Because I believe it's more than 5 minutes according to the new guideline, right?
Sorry.
Asthmaticus,
Yes.
we can say this unit is more than 5 minutes according to the new
On response to the asthma. Yes. So he might be. Well, we don't know, but we do our job. Yes, we do our job. We don't need to know the definitive diagnosis. That's the good thing. That's the good thing in this assessment. We don't need to do the definitive diagnosis. We are just dealing with the findings. So we're starting our ABCD approach. A, his airway is patent, but fatigue. What do you know? What is mean? What I mean by fatigue? How how could I know he is fatigued?
Maybe using
Yes.
external
Yes, he cannot complete a sentence, and you find him sitting in a tripod position. He is using his trapezius in order to help his respiratory muscle. Okay, so looking at the patient sitting in a tripod position means he is fatigued. His respiratory muscle is fatigued. So this is an important thing. And as doctor said, he cannot complete a sentence because of the shortness of breath. What to do at this point? Well, ABG is somewhere, yes, later on. So you are, yes, we might start auto as soon as possible. What I mean by repairing intubation, because auto we already mentioned that in the B, so I don't want you to be confused. So in the A, either do nothing or intubate. Maybe using a mouthpiece like nasopharyngeal, yes, oropharynx or nasopharynx to keep the airway patent. So the oxygen would be in the B more. No, I mean preparing for an intubation. We will not intubate a conscious patient. We give him some medication. We try what we can. The anesthesia, yes, it will be standing beside us, and we manage and monitor the response. He might respond just simply, and we don't need to intubate. Breathing, his finding is tachypnic with a silent chest with low SpO2. What would you do? Perfect. Sorry? Yes, we already prepared the intubation. So when we find these findings, do you intubate according to these? I will not intubate until I see that he is not responsive. But what doctor says is something new we didn't discuss earlier. We use an non-breathable mask, but we might use a ventilation nebulizer mask. Okay, we give an O2 through a nebulizer mask. We don't use this regular nebulizer device, which is using a device compressing air and nebulizing the medication. No, we are just nebulizing the beta agonist through air oxygen drive mask. Okay. So we give an oxygen and we give a nebulized bronchodilator and the steroid. So I just say that we nebulize the bronchodilator and the steroid. We do not give an IV because this is in the C. Okay, we nebulize the beta agonist and steroids, and we might order for chest X-ray. Yes. What we have is just Ventolin nebulizers. This is the available medication. Yes, this is a steroid, the inhaled steroid, not a beta agonist. Circulation, he has have a tachycardia. What do you think? So, yes, so what you should do in the C? Yes, perfect. Then, perfect. Take, then, give what? Perfect. We should give some medication. We don't need to give fluids at this point because he have no problem with the circulation. You might give a fluid, but it's not urgent. The most urgent thing, you give something IV. What would you suggest to give this patient? IV steroids. Yes, perfect. Steroids, like a hydrocortisone, which is a fast-acting, rapid-acting steroid. Then IV access and giving some steroids. I don't know, this is not shown, but okay. So we give some medication to help with bronchodilation. Well, as an orthopedic, I managed status medicus brevis in my rotation, but now I don't know. I don't even remember the name of this medication, but it's not a part of the ABCDE job. I don't, need to give according to the detailed medical guidelines. You might know that. You might call for some more senior doctor asking for his advice. Should I give? And then when he says yes, you can start with these. Okay. In the D, he is agitated and fatigued. What should we do? So I mean, this is in his mentality. He is agitated because of the fatigue. So what we should do? Yes, monitoring. Because if we relieve the problem from the B, he will be improving. You don't need to give something to him. Watch for CO2 retention. What I mean is that his agitation is due to CO2 retention rather than hypoxia and the decreased perfusion in the previous cases. E finding no trauma. So what we should do? No finding in the E. So what we should do? Avoid hypothermia. Sorry, because we expose him, we just recover him. Okay. Continuous assessment. Yes. What we should do next? Yes, consult for and anesthesia because he might need an intubation. We already mentioned that. And then, yes, perfect documentation. You always remember to document. That's the most important thing to you. Yes. So the monitor for the response according to your management, call for a specialist and document. He might need an ICU admission. Okay. You should document. You should document. Even in many cases, Dr. Ahmed knows that some patient present, we do a resuscitation for hours maybe. After these hours, we just sit. After the patient improved or died, we just finish and we sit. We are our call ends on 2 p.m. You might stay in the ER or in the ward for 2 to 3 hours after your call just to document what you just did. And that's not in our locality, just it's an international thing. You will not leave the institution until you finish the documentation, and you should never leave the patient die and document to protect yourself. You need to finish the patient job and then document slowly. Okay. So that's why after finishing and handing it over to the specialist, we go to the documentation. I never put a documentation from the early beginning. So you don't need to keep the patient dying and you go to protect yourself and document, but you need to document. Sorry, this is an old man. We are advancing in age until we reach graveyard. So this is a 70-year-old male. He have a fever, cough, and confusion. What do you think? Good, 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 good. So both of these diagnoses you mentioned it means an infection. So that's a good thing. So we start from an infected patient. So we have infection somewhere, and that lead us, yes, maybe, yes, it's some respiratory or other, because he have a confusion, and there is something called confusional state of elderly. The elderly patient, whenever he is under stress, whether a simple trauma, whether it's a surgery, whether it's an infection, he suddenly become confused and delirium. So it's called the acute delirium. So an old patient with a confusion is a simple thing. It might be UTI. He has complaining of a simple UTI. He will develop a delirium, and his family thinks that he will never gain his consciousness again, which is not the right thing. It's reversible. Yes, it's the elderly patient is more susceptible for delirium, for a simplest stress. Yes. Yes, it's an acute confusional state of elderly. Yes, it could be due to some permanent damage, but in many cases, it's a reversible thing. So you don't need to afraid and think about the brain from the beginning. Any stress to the patient will make the patient be in an acute confusional state. So, sorry. Yes, we are going to ABCD approach. First, in the A, the airway is patent. What we should do? We just go next. In most of the cases, I mean, in many cases, in 90% of the cases, you will find that the airway is patent. So the A, you should do A, you should, but in most of the cases, you will not do nothing. You just pass that, okay? In most of the cases, if his airway is not patent, I told you that you need to escalate that for some more senior doctor. But in many cases, it's patent, in most of the cases. But you do not need to forget that. It's your job to check for it and be sure that it's okay, then move on to the next one. So just monitor it. Breathing, he have a tachypnea and crackles on the auscultation. That give us an idea about, yes, some respiratory or some lung disease.
Some kind of obstruction happening.
Sorry?
There is some kind of obstruction happening.
Yes. The crackles is toward the fluids. The fluids, the interstitial fluids, like the pulmonary edema, will cause crackles rather than the pleural effusion, which is outside the lung. So some fluid inside the lung will cause crackles, okay? And then the obstruction, there is other sound. I mean, I believe it's a wheezing sound. I don't remember the name. Some wheezing sound with obstruction. Wrong. Yeah, maybe. Yes. It's the wheezing, which means as there's some obstruction and airway is the air is passing through some narrow thing. Strider is an upper airway topic. We are yes. Okay. I'm not a medicine specialist. I'm sorry. I'm an orthopedic. We are not wearing a stethoscope anymore, so we are not a school thing. Yeah, I don't know, but basically we just know that there is some fluids maybe or something like, even if it's a wheeze, it's the same. It's not that much. What we should do? Perfect. We need to order. We keep in mind that we need an assessment from the early beginning, but we will not send the patient to the X-ray until the portable X-ray arrives. There's some portable X-ray. So when you order for an X-ray, you are continuing your assessment, and they sliding the film, they taking the shot and show it to you. That's what means by X-ray during the beat. Oxygen, that could be using a ventilation support because he's an elderly and confused, but that's not a mandatory thing right now, and an X-ray. Circulation, he's have a hypotension. What do you think? Why he does have a hypotension? Perfect, good. It's a shock, and mostly it's a septic shock. You think it could be a hypovolemic? I don't think it's a cardiogenic. Maybe. Obstructive? I don't think so. Okay. Okay. So we go to. Oh, I didn't ask what we should do. You. Yes, perfect. You secure an IV lines. You give and then you take. Yes. Um, you give and you take three of the sepsis. You take the three of sepsis. You take blood culture, lactate, and blood urine output. Sorry, this is specifically for sepsis cases. And you give three things. You give oxygen, fluids, and antibiotics as early as possible. The antibiotics is in the C. You cannot delay that until you are sure of the diagnosis. You just take a sample for blood culture in order not to be obscured by the antibiotics, and you give antibiotics as soon as possible. Do you agree with me with that? Yes. Why it's in urine output? No. Perfect. The perfusion to the kidney, so you just know that if he enters a multiple organ dysfunction, so the patency of the presence of urine will give you an idea about the perfusion to the kidney, and if he's anuric, it might have dysfunction in the urinary system. Then the D, sorry, he's confused what to do. Yes, exactly. Continuous monitoring. He might deteriorate more, so he need a more invasive intervention. Check for. Sorry. Yes, this is a very important thing. In the D, we do not need to forget to check for glucose and then monitor, because he is an elderly patient. So even he have a fever, his confusion might be due to hypoglycemia. Can anyone explain why in such a sepsis patient we suspect hypoglycemia? Yes, the infection, the bacteria. Yes. So glucose. Exactly. So the consumption of the glucose from the bacteria will cause a hypoglycemia, and also he's confused. So we think that he missed his previous two meals. So the adaptive mechanism of the body will not catch up because he's elderly, and also he has this bacteria which consume glucose. And exposure. He have a fever. We should measure that in the D. And infection signs. Infection signs like if he have a rash on his body, and if he have any other infection signs like maybe have a sputum, or have any other signs of infection elsewhere. Might be have a diabetic food or anything else. Okay. And in the management, we just give a broad spectrum antibiotics. So I mean, when you have a patient with an obvious diagnosis in the E, when there's no trauma or bleeding, you don't have much to do. You just need to keep in mind that there is E. You need to expose the patient from head to toe, and according to the finding, if you have a Foley's cut, what would you do? What do you think? Sorry? Yes. I mean, what would you do? Yes, or replace the Foley's cut. We need it, so we just remove it and secure a new one. Okay. Yes. What would you do next? No, we hand over the patient, then we document. Yes. So perfect. Reassess, and then consult more senior doctor. In this case, who would you consult? Could you call the orthopedic for that? Yes, medical, and maybe anesthesia if his glucose. Yes, perfect. And then order or recommend further investigation. At this point, you give your opinion. Yeah, I mean, you recommend or send investigation. You either send them if there is no one else to take the patient, or if you give the patient or hand over the patient, you recommend for him something to do. And last thing is that documentation. Admission to the ICU in such a case, because he need a multidisciplinary team management. Well, yes. Okay. We finished. Yes, we have a few. We did. Okay, this is, I believe, the last case. So he is a 55-year-old diabetic who found unconscious at home, and their neighborhood called the ambulance. The paramedics bring him to the ER, and you just approach this patient. Seeing him in the ER, the paramedics secured an oxygen during the transportation time, and just this is the patient. What to do? What do you think? Yeah, you are suspecting hypoglycemia. Yes.
Yeah, most likely.
Yes. Sorry.
There's different doses for unconscious.
Perfect. You just don't go through. Yes. You don't need to jump. We will never jump. Yes. Yes. We never jump. We start with the A, then B, then C. He might have hypoglycemia simply, and then he loses consciousness and swallowed his tongue. He was conscious but confused, and then he swallowed his tongue. He have an obscured airways. He have cyanosis, hypoperfusion to the brain, and unconsciousness. So you never jump. You might order someone. You ask one of the nurses around you to check for glucose while you are doing your ABCDE. As a doctor, you never jump. Okay. ABCDE. The airway is compromised, so he swallowed his tongue. What would you do? Sorry. Yes, we need to do these basic things. Yes. So we need to protect airways, whatever the method you say, even maybe intubate the patient. So we need to protect the airways. In the B, you have a normal breathing pattern. What to do? Giving an oxygen. Always give an oxygen. Yes, but you just say I would give an oxygen. Okay. So you just keep in mind in most of all the critically ill patients we secure an oxygen. Okay. Oxygen. Circulation. He have a tachycardia.
Nebuline.
Perfect. Yes. You might give fluids. Perfect. Yeah, we take an investigation involving an ABG. And we give these things. The glucose level is low in the D because we check that. His consciousness is low, but his glucose level is low. What to do at this point? Perfect. Yes. Dextrose. Do you know what is the disadvantage or the side effect of the dextrose 50 if you give it directly? 50%. Yes. Yes. It's her answer, so it's her complication. She should deal with that. What would you do to avoid these things? It's a return to the veins, so perfect. Perfect. Thrombophlebitis, the diagnosis which causes thrombophlebitis. So we don't give it directly. We are just infusing that. It's okay. It's okay to have a hyperglycemic in an unconsciously hypoglycemic patient. Okay, it's a protective for us. Then going to the immediate IV dextrose. In the finding no trauma, what would you do? Yes, we just do reassessment. So if you do a reassessment and find that his glucose level is high, what would you do? Is that the end of our management? Stopping that? Are you agree with her to stop the glucose, the IV glucose? Sorry. Yes, the maintenance, because the effect that caused the hypoglycemia he might have taken overdose of the insulin, and the insulin effect will last longer than the effect of the dextrose, so he might enter in a hypoglycemia again. So we should keep him on the IV glucose until he take a oral feed. Okay, until he take an oral feed. I don't know what's written here, but missed meals. Yes, okay. Yes, we search. What would do? Yes, reassessment, perfect. Then, do you want to consult for such a patient? Maybe not. If I just managed a few cases of hypoglycemia, and he just from a state like a dead man to walking to home in 15 minutes, maybe. Yes. So and documents, monitor response. You can consult documentation. Maybe ask your admission if he is not responsive. So one of the fates of this patient is admission to the ICU. That's all. This is my academic account. If you want to contact later on, I just want to highlight the importance to remember these things. You need to check for the airways in the A. You need to check for the breathing in the B. Then going to the third. Never jump. Whatever the even if the diagnosis is obvious, apart from a massive external visible bleeding, you just control the bleeding and go back. And on other situation, you just follow the protocol. And this last patient was an example. He swallowed his tongue and he has a compromised airway, despite that the obvious diagnosis is hypoglycemia. That's all. I am very sorry for this very long lecture. I wish this was beneficial for you, and it's an honor for me to meeting you today.